Buenas tardes. Muy agradecido por la presencia de todos vosotros y felicitaros por el aguante ante esta maratoniana sesión. Para un entusiasta de la ecografía, como soy yo, desde hace 30 años, esto me parece, la siguiente presentación me parece probablemente lo más novedoso de la reunión, lo que en el futuro nos puede traer más satisfacciones o también más decepción. Por mi edad ya soy bastante escéptico. Tendríamos que aprender un nuevo patrón de ecografía transrectal con esta nueva máquina, pero a mí verdaderamente me produce excitación el tener una máquina de estas y poder utilizarla y ver todas sus posibilidades. Es una máquina con la cual se puede hacer toda la ecografía convencional y tenemos la ventaja de poder realizar exploraciones transrectales con 29 MHz y ahora vais a ver lo que nos exponen en los dueños del producto. Su intención es que dejemos de utilizar la resonancia en el futuro y el urólogo solo puede hacer todo, no solo el diagnóstico, no solo la biopsia transrectal, sino también la terapia focal o cualquier otra terapia que se utilice, ultrasonidos como la crio, la HIFU, etc. El doctor Sangeet Ghai del Hospital Princesa Margarita de Toronto nos va a presentar este producto. Él es radiólogo y ya está involucrado en el producto desde el inicio de la investigación y del estudio clínico.
Thank you so much, Dr. Casper. Thank you, Dr. ExactVuTM, for inviting us here and giving us this opportunity to speak about this exciting new technology. We have some experience with this, and I would love to share this with everyone in the audience here. Can we have the lights down a little bit? I just want everyone to look at the images as well. We've heard a lot about MR as an imaging marker this morning, this afternoon, and I would like to introduce here a new imaging marker which we think will be very good to all of you here. So to start with, what is micro-ultrasound? Why do we call it micro-ultrasound? And if I can actually go back on this slide, micro-ultrasound, what we are referring to here is just ultrasound, but with high frequency. So generally, when we do a transrectal ultrasound, we use a 6 to 9 megahertz transducer. Here, we're talking about ultra-high frequency. We're talking about 29 megahertz transducer and the opportunities that it opens for diagnosis in prostate cancer. I'm hoping this video will play the first so as you can see here on this video, the hypoechoic that you see here is actually an old needle biopsy site. It is showing us the tract of a previous biopsy. So you can appreciate the resolution that this device has and what it can help us in evaluation within the prostate gland. These are my disclosures. We are part of a multi-center study that is ongoing at present. It is an industry-funded study across 5 sites, 3 sites in Canada, we being one of the 3 sites in Toronto, 2 sites in the US, one of the sites being Johns Hopkins University Hospital. And I'll talk about the study a little bit more as we go on towards the end of my presentation. So before I talk about why micro-ultrasound, I think it's important to know what is micro-ultrasound. So as I said earlier, it's an operating device which operates at about 29 megahertz, that's the higher end of the frequency, as opposed to the 6 to 9 megahertz that we use for our routine standard conventional truss imaging and biopsies. So what this means, it provides us a resolution which is 300 times better than a routine standard conventional truss ultrasound. The commercial version of this application is going to be available, I think, in the next 3 to 4 months in Europe and about 6 months in the US. We are conducting a study under IDE, which is exemption from the Health Canada and FDA to run this present study. So why micro-ultrasound? This has been discussed in great depth throughout this afternoon. We know the problems that exist with the systematic biopsies. About 40% of the cancers are not going to be detected. And from all our learning, when we do a transrectal biopsy using the conventional device, we have been taught that, try to target the hypoechoic or the darker areas that you see. But we also know that the positive predictive value of most of these hypoechoic areas to come back as a significant cancer is about 20 to 40%. So that is a problem. We know that truss ultrasound is not very sensitive. It is not specific as well. And that is why we keep looking at other imaging possibilities to help us direct our biopsies and have lesser degree of false negatives. And that brings us to MRI, and then MR truss fusion. This has been discussed at length. I'm not going to talk about it, but we know that MR has its limitations. Access to MR can be an issue. It is expensive. There is a learning curve for the radiologists. I do report prostate MRs at my site, and I can tell you there's a learning curve. It takes a while to gain expertise in reading them. So those are the drawbacks of having an expensive imaging tool, of having to use MR truss. So the question comes back, can we actually make it again an office-based tool? Can we actually have a new imaging tool, an ultrasound-based imaging tool, which will perhaps visualize cancer better than what we do at present? And it's that quest which brings us to a high-resolution scanner ultrasound imaging using a high frequency. So been through this. So on this image, on the left-hand side, you have an image from a standard truss image, a transrectal image, which was done at 6 to 9 megahertz. And on the right-hand side, you'll appreciate the increased resolution that you get with a 29 megahertz transrectal scanner. So you can appreciate the borders, the margins, the architecture of the gland, the texture of the gland, much, much better than what you would do with a standard truss ultrasound. Now, why did we select, or why did the industry select 21 to 29 megahertz? Because you also have to see the prostate. So you get an increased texture. The higher frequency you go, you're doing that at a cost to the depth. So at about 21 to 29 megahertz, you can see about 5 centimeters interiorly in the prostate, and most of the prostate, I would say, in AP dimension would be covered at about 5 centimeters. So again, I won't go into much detail. If one could argue that this high-resolution ultrasound, if it takes you away from using a fusion device, if you can see a lesion now, you can actually target it in real time rather than having to use a fusion device. It is office-based. The workflow is going to be much quicker. It is less expensive, and it is probably an easier way to detect significant prostate cancer. So I'll go back to how this all started. And there was an initial pilot study which was done at Johns Hopkins. We were not a part of this pilot study. This was led by Dr. Pavlovich, who is a urologist at Johns Hopkins University. And they consented 25 patients who had already been consented for a radical prostatectomy and scanned them using a standard truss ultrasound device as well as this high resolution. Or the person who was performing, the physicians who were performing the scans were blinded to the path report, except for the fact that they knew that the patients have consented for a radical prostatectomy. They knew that patients had disease and they were going to have a prostatectomy, but they did not know where the disease was, what was the Gleason score, was it one site, was it more than one site. So the radiologist and the urologist actually evaluated the images. They marked out the sites which they thought were cancerous, both on the low-res and the high-res ultrasound. And to come back to the results, they saw that on the high-resolution scanner, the sensitivity increased by about 73%. And the specificity also increased by about 9.5, 10%. So they were picking up the cancers much better than was being picked up by the standard truss ultrasound. And not just for all cancers, if you were to just include the significant cancers, so the higher grade cancers, the detection was 84% versus 60% in favor of the high resolution ultrasound. And I think if I remember the numbers correctly, there were about 22 cancers which were picked up by the standard truss ultrasound and about 34 cancers which were correctly picked up by the high resolution scanner before the patients went on to a radical prostatectomy. So it was the data from this initial study which prompted a multi-center trial, a much larger study. This is across the 5 sites that I earlier mentioned, one being our site. 2,000 patients. It's a randomized prospective study. 1,000 patients go on to have a biopsy under the standard truss conventional ultrasound, and 1,000 patients will end up having a biopsy using the high-resolution scanner in this study. And the hypothesis here is to demonstrate the increased cancer detection rates using the high-resolution scanner as compared to the standard truss ultrasound. As yet, we have crossed the halfway mark. I think we've done about 1,100 to 1,150 patients as of today across the 5 sites, and we still have about 900 patients who are going to have a biopsy. The results are confidential. We cannot discuss the results till the study is complete, which will take another 3 or 4 months across the 5 sites. But I will be sharing some initial impressions and images that we have from the study. So here, as you can see, on a high resolution, you can easily appreciate the peripheral zone from the transition zone. You can appreciate the urethra. You can see the ejaculatory duct very well. So the intrinsic detail that you can see, the borders between the transition zone and the peripheral zone. Now, I can take you back to PIRADS and MR, and we keep talking about, yes, the multiparametric MR is not as good when you come to transitional zone. It's all about morphology, because that's all we rely on when we try to detect cancer in the transition zone. Perhaps this can give us more information. Is there actually a breach between the transition zone and the peripheral zone? Or is that a reason for us to be suspicious that there is actually a cancer in the transition zone? So that's where this can definitely help. So another example, this was a Gleason 8 tumor. You can see those hyperechoic, tiny hyperechoic foci, an area of comedonecrosis, as I would call it, a darker area with a few bright spots, a starry sky appearance. From our experience using this high resolution, almost always such an appearance came back as a significant or a high-grade tumor. And then, if you can appreciate here, this is a large tumor. You can see how it bulges the capsule. Probably there is a breach of the capsule as well at this site. And I can assure you that this lesion is going to be very difficult to see on a standard truss ultrasound. So that's where the advantages of having a high-resolution scanner does come in. So with this high resolution, we can go down to about 70 microns, which I said is about 300% better resolution than a standard truss, conventional truss ultrasound. But then with this comes the question, do we actually understand the images itself? Because it's all new to all of us. It's new technology. Certain images we don't know how to interpret. So with all this data, to understand what is normal and what is an abnormal prostate on such a high-resolution scanner? How do we distinguish malignancy from a benign appearance? And there is a need to have an evidence-based protocol. So what we did in the study was, at midway, we put on hold to the study. We evaluated the images. So every time the investigators take a biopsy, we take a cine loop. We capture a cine loop. There's a foot pedal. And then, so we selected about 200 to 300 cine loops with the pathology feedback, correlated, looked at all the images, and then there was a learning curve for all of us to identify what actually cancer looks like on a high-resolution scanner. So we did that, and again, showing some of the examples. So we saw the Swiss cheese pattern on the left-hand side of your image, the ductal ectasia, as we would call it even in the low res. Almost always, this would come back as negative, as benign. On your right-hand side, you have slightly heterogeneous but hyperechoic areas. It's more brighter, with some ductal patches. And again, from our experience, this almost always would come back as a benign or a negative site. And then there were certain other appearances. So you can see heterogeneity. There is a hypoechoic area. There is a more hyper and a hypo. Similarly, darker and brighter areas. This was benign. This was actually cancer, a Gleason 7 tumor on the biopsy. And one could argue that perhaps the transition from the hypo to the hyper is perhaps a little more abrupt here. And this is the lesion as compared to this area where it's a relatively slow transition. So, and then there were certain other features that we learned were very characteristic of tumor on the high-resolution scanner. This was, again, the comedonecrosis that I spoke of earlier, came back as tumor. Now, this appearance, you would probably call it a cauliflower appearance if you can appreciate brighter areas with darker hypoechoic bands, alternate areas, a giraffe pattern perhaps, a cauliflower, a mottled or smudged appearance. So this is the lesion, which, again, would be very difficult to visualize on a standard 6 to 9 megahertz transducer. And this was cancer. The few times that we did see this pattern, this almost always came back as cancer. Again, when we started seeing irregular shadowing, you see those shadowing which start from the prostatic capsule. It's important that these are intraprostatic lesions, perhaps because of increased cellularity in that area. We saw those linear kind of hypoechoic bands, shadows running more anteriorly into the prostate. That was another sign that this is a cancer. And then, I'm not sure if you're able to appreciate there, this is a lesion, certain areas of hyperechogenicity with a hypoechoic or a darker band around it, which is somewhat irregular, going up to the capsule. So this is a relatively large lesion. This is perhaps more than 6-7 millimeters in size. It, again, would be extremely difficult to see on a conventional ultrasound. So what we did was we tried to simulate what has been done in MR. So we had the PIRADS. We put forward a Primus scoring system. And as you can see, we had the Primus 1 and 2, which almost always would be benign, almost. The PIRADS, or the Primus 3 is similar to the PIRADS 3. I showed you some examples where they were heterogeneous. One of them was benign, one of them was malignant. Very similarly, we had the Primus 3, which was, again, perhaps 40 to 50% of the times came back as cancer, but not always. And then the other, the higher scoring system, the Primus 4 and 5, would almost always come back as cancer if we saw these patterns at the time of the biopsy. So this was what we initially developed and has actually now been accepted for publication in the Journal of Urology. It is in press. You can access the publication online through PubMed. So then we wanted to validate the Primus score. What we did was we had 5 readers, and again, a mix of readers. 2 of them were urologists, There was one radiologist, one sonographer who had lots of experience with prostate ultrasound, and one physicist who were trained on the primus. So the data that we had, they were trained over 1 hour to look at the images. They were given a few examples to look at them, and then each of them was given a workstation and given 100 cine loops, 100 images, to assess the images and give your primus score. They were blinded to the pathology at this time. So it took them a few hours to do this for the validation of the primus. And what we found that with only 1 hour of training, whether it's a radiologist or a urologist, all investigators achieved statistical significance in detecting cancer using this new ultrasound device. So what I'm trying to emphasize here is that the learning curve is not difficult. It is, once you have been shown the images, once you have a little bit of experience, the investigators were able to achieve a level of significance there. We also saw that the increasing risk score, so if you go to a primus 4 or 5, predicted higher Gleason score and a higher percentage of the core involved. So if you would call it a primus 4 or a primus 5 category lesion, the chances that it was a significant tumor was actually pretty high. So in this 100 studies, 100 cases which were read by the 5 reviewers, the area under the curve was about 60%, but went up to 74% when we included Gleason 8 and 9 visualization. There was very good, relatively good consistency between the readers, as I mentioned, given that they were only trained for 1 hour. They were exposed to this new imaging patterns only for an hour. And we also saw that the primus scale linearly related to the cancer risk. So as I said earlier, the higher score you give, the chances of a higher grade cancer was there. But mind you, this is only the first version. There's certainly going to be refinements. It is early stages. And we're talking about, the industry is actually talking about adding a multi-parametric approach. So in the future, we will have Doppler, we will likely have contrast ultrasound, and also perhaps elastography. It might take a year. I'm not sure about the deadlines, but I guess it might take about 6 months or so. The micro-Doppler, I'm told, is going to come in the next very soon, actually. So as I said, we've done about 1,100 biopsies or so. From the second phase after the first 1,050, we are also prospectively validating the primus. What we do at the time of the biopsy is every time I'm taking a sample, I actually call out and I give a prospective score, 3, 4, 5, when I take a biopsy, and we're collecting that data to see if we need any further refinements. And to validate, we're hoping that our cancer detection rates with the new learning in the first half is actually going to go up even more when we start comparing the second half to the first half of the study. Thank you so much. Be happy to take any questions.
Supongo que todo el mundo tendrá 1000 preguntas. El doctor Bernardino Viñana.
Felicidades por la presentación. Yo esto lo veo parecido al T2. Habla de la ecografía multiparamétrica, el añadir la capacidad de la elastografía. Mi pregunta concreta es, ¿el contraste ecográfico microburbujas aportaría más resolución, que sería el equivalente de la multiparamétrica de la resonancia? La elasto, la imagen en B, que es la que estamos viendo de microburbujas, el contraste ecográfico con microburbujas añadiría más información.
How do you understand?
No, I'll have to take a. Can I?
Sí. Mi pregunta es, pensando en la ecografía multiparamétrica, si el contraste ecográfico con microburbujas podría aportar más información al añadir datos de hiperperfusión en esta zona, más allá del Doppler, de la elastografía, del contraste ecográfico.
Yeah, it's a good question. It's too early to answer, is what I would say. Yeah, it's a good question. It's too early to answer that. It may perhaps. I know when you talk about MR, DCE is usually not a good parameter. We rely a lot on T2 and we rely a lot on diffusion still. But I think it's worth testing. We hope to do that eventually, and we'll probably have results at that time. Is that, we have CT and MR on one side, we say for liver hepatomas, but we know that contrast ultrasound has a definitive role. Even lesions like FNH are more easily and readily diagnosed by contrast ultrasound many times. So it may have a role, but I think it's too premature for me to give a conclusive answer at this time. It's still early days.
Es que me sabe mal hacer trabajar a la gente a estas horas, pero yo pienso que la diferencia, yo creo que Bernardino, yo no estoy de acuerdo con tu visión. Es decir, voy a ponerte un ejemplo. Si tú haces una cistoscopia y ves una lesión y la biopsias, nadie te pedirá que hagas una cistectomía, porque has biopsiado esta lesión y es lo que quieres que te conteste el patólogo. Él está viendo una lesión que biopsia. Y es esta lesión la que ha biopsiado y la que quiere saber a qué corresponde, a qué anatomía patológica corresponde. No le importa la prostatectomía. ¿De acuerdo? En cambio, con la fusión y con la resonancia, estamos, mejor dicho, porque yo las hago sistemáticamente, con 3 Tesla, por cierto, estamos biopsiando sombras y es normal que una cosa que tenía que decir en toda la tarde y no me he atrevido hasta última hora, que quedamos 4 gatos y ya no importa tanto el tiempo que os haga perder, estamos haciendo mal las biopsias. Y las cuentas que estamos sacando de la resonancia y de la no sé qué y tal están mal contadas, porque son las biopsias las que están mal hechas. Bueno, menos mal.
So if I can just respond to the first part of the comment that you'd made, I think we're gathering data for the negative predictive value as well. So when we do the biopsies, we don't just target a lesion. This is the first study. So we do the 12 core, irrespective of whether we see a lesion or not. So even if we don't see a lesion, we do, from that sector, we do take a biopsy to get the data to see what the normal appearance is. And the first study, as I said, was correlated with radical prostatectomy, which was done at Johns Hopkins.
Yo lo que veo con este aparato es que ya había un avance el año pasado en el Congreso Europeo de Urología en Madrid, ya se nos presentó. Creo que con los resultados que has presentado y que van a salir en el futuro menos sesgados, dijéramos, es que hay que aprender de nuevo a ver imágenes totalmente diferentes. Es decir, no tiene nada que ver las imágenes que nos has presentado y que van a salir en el futuro, máximo si se añade la elastografía, etcétera, con lo que es la ecografía convencional. Entonces, yo creo que va a ser muy importante que las imágenes y los parámetros que nos presentes con el Primus, por ejemplo, 4 o 5 y demás, se correspondan exactamente con un valor predictivo positivo. Es decir, que sean las imágenes que te digan aquí hay un cáncer, efectivamente se corresponde con un cáncer. Y eso lo vamos a tener que aprender todos con este aparato porque son imágenes de alta resolución que nada tienen que ver con la realidad hasta el momento actual. Me explico, ¿no?
Very good point. Totally agree. There's a learning curve, as I said, but I think the learning curve is not as difficult, for sure. 5 readers could learn it in 1 hour with relatively good results. What is the positive predictive value? You know, we talk about MR. Positive predictive value of a part 4 could be about 50 to 60%, 50%, 60%. Part 5 could be about 80%. Part 3 could be about 20%. But I think, you know, as we gather more data on this, we'll probably have a better idea. Once we have 2,000 patients, so 1,000 in the high resolution arm into 12, so 12,000, 12 cores in every patient. When we have 12,000 patients and we analyze, we'll have clearer data at that time as to what is the positive predictive value of the kinds of lesions that I'm showing here. And I think at this stage, in the 200 cine loops that we evaluated, they were pretty high. So for a Primus 5, I think was, the publication says it, but perhaps more than 70%. And a Primus 4 would be more than 60% for a positive predictive value. But again, a smaller database at this time. Once we've done 1,000 patients and we'll have 12,000 images to review, we will certainly have more data.
Okay, Dr. Ghai. I beg your pardon for being the last one. I think this is the most promising thing we have ever seen. It's a new concept of transrectal ultrasound. I think we have a long way to learn, but in a very exciting way for the urologists, that we can do our own diagnostics. Thank you very much. We are going for...
Thank you so much for having me.